So now we're going to discuss eating disorders, anorexia and bulimia. First, we'll start with anorexia. Some of the signs and symptoms of anorexia is when a patient is really restricting, how much energy intake they are taking in and doing. They really are exercising a lot, and they are just, wanting to keep losing weight, and they are not taking in calories to really sustain life. They're taking barely anything, and they're a real intense fear that they're going to gain weight. You can see in my picture here, this person looks as skinny as can be, but they feel that they might be so big. They might even feel that they are like 300 pounds. There's a real body image disturbance. You can tell that, not to be judgmental, but this patient would not look healthy and well nourished. So there's a big body image disturbance, right to the point where sometimes you definitely can see their ribs sticking right out in their bones and just very unhealthy. There's an electrolyte imbalances. These patients, their electrolytes are all off, their potassium, their sodium, lots of issues with that. Cardiac dysrhythmias can happen. Everything connects here. If your electrolytes are off, you're at risk of having cardiac dysrhythmias. And if your body is not taking in enough fluids, think about dehydration. Just think about the whole body here. Skin changes are happening. They might have dry skin, just very, not healthy, enough nourishment to keep them, being healthy and alive. Muscle wasting is happening. They're not taking the protein and calories in to sustain, health. Then we have bulimia nervosa. The signs and symptoms of that, they're similar to anorexia. The patient's going to have really compulsive behaviors. They might sit there, eat 2 big pizzas, and then they're going to self-induce vomiting, get rid of the food. They've had the flavor, they've had the taste, they've taken in those calories and gotten that behavioral need in, more than enough food, and then they're going to get rid of it. They might then carry on to take laxatives to the point where they're taking more than the normal dose. And they might also, if they can get their hands on diuretics, misuse those. I've seen patients to the point where they are just trying to do anything to get that weight right off. And again, that can lead to all complications that we discussed. Excessive exercising can happen. We're not talking about having a really good workout. We're saying hours of exercise to the point where, they're going to drop. Another key indicator here that you will see is the patient could have tooth enamel erosion. So when the provider is doing an oral assessment, you will see behind the teeth that enamel is there's an erosion. Also, calloused knuckles are a really big indicator that somebody is purging. They call it purging self-induced, vomiting. Some therapeutic interventions for both. We really, number one, want to have that patient be healthy and alive and restore that nutritional health. That can be done so many different ways. It could be IV infusions, get those electrolytes back where they need to be, bags of fluid. It could be oral supplements, thinking about vitamins, supplement drinks, things like Boost, Ensure. It could even be feeding tubes. When I say oral supplements, let's add even in feeding tubes. If that's really severe cases, they are also going to need a combination of psychotherapy and really work on stemming what the problem is and looking at behavior modification. Getting that patient to the point where they can have a nutritious meal, have a couple pieces of pizza, and not feel that they have to go get rid of it. Lots of education. It's lots of patience. It's not judgment. It's just, really figuring out what has made this patient-centered care, come to the point where they are having these types of eating disorders. So some of the nursing diagnoses, you could have imbalanced nutrition. They're not taking in what they need. Their weight's not where it needs to be for their normal weight and height. Their labs are off. We talked about electrolytes briefly. Their vital signs are not where they need to be. If they're dehydrated, we're going to have all kinds of problems. If they're in cardiac dysrhythmias, lots of problems. Again, each patient's going to be different depending on the severity, depending on their body and what they're doing to it and where they are in that process of their eating disorder. You really, 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 as a nurse, want to build trust. We're not there to be judgmental. We're not there to tell them that they are too skinny or they are a good weight or any of that. We really got to hear our patients and really build that trust bank. And we have to provide a real pleasant eating environment. They can't feel like I've got to eat, like it's taking an injection or something that's terrible. To these patients, eating is really terrible to them. So the more we can do to provide that pleasant eating environment, giving them foods they like and portions that, are good, that they can handle, and making sure that they don't go and, get rid of it. A big thing they do in the eating disorders, I know when I did some training over at Brattleboro Retreat, they did a lot of small meals, protein meals, high in protein, and approximately, it depended on the patient, 6 small meals a day. Because if you could get them to have small amounts of healthy things, that was better than them sitting down for 3 squares or even 2 big meals and a small meal. Those little meals, just thinking about it, seemed like a small amount, but in the end, they add up to be the caloric intake that they need. So then you have, for another nursing diagnoses, you've got disturbed body image. Assess responses to the body. If you are, doing some one-on-one time with a patient and they are just, really disgusted about how their body is, it's really that open-ended questions and communication with that patient and really listening to what their concerns are, because that's going to be part of your documentation if you're working on a psychiatric unit, because we've got to figure out what we can do, the providers and, the specialized nurses, what they can do to do a patient-centered plan of care. Listen to those patient concerns. This will be a time where you're doing some individualized documentation. Refer them to counseling. I mean, if they're on a specialized unit, they're getting counseling, but say it's an outpatient or something, they might need a referral for some counseling. Again, over and over, I tell you, provide non-judgmental care. We really, really would never be judging our patients, but some of these cases can really be, heartbreaking, and just to the point where you didn't realize, that patients could be doing these things. So we just have to really, again, no judgment, looking to make this patient healthy, positive reinforcement. If that patient eats their snack, they have cheese and crackers and they have a glass of milk and they have it and they enjoy it, really, genuine positive reinforcement. I know we used to do things like journaling and things. I mean, now with all the technology and smartphones and everything, people can keep logs. But I remember everything was like a notebook. And patients would really, really be proud of themselves if they could eat a meal, tolerate it, not purge it, not vomit it when I say purge, and really keep it down. And, they would have bad feelings. If they could talk those feelings out with a person they trusted, it didn't make them want to run to a bathroom and get rid of that food and feel bad about themselves. That positive environment and non-judgmental care really made a difference. Now we're going to look at mental illness in older adults. Again, this is very brief. You're really looking at physical and mental disorders. We're distinguishing between them. There's neurocognitive disorders, major and minor neurocognitive disorders. We have for Alzheimer's. You've had your training on that. That is not temporary. That is permanent. The patient goes through stages to the point where they are, total dependent and not doing anything in the end stages. Then we have vascular disease. That's when our vascular system is not working the way it should. There could be some blockages and some changes in, mental status and behaviors. Can we do anything to fix this vascular disease, or is it, something that it's so severe? It depends where patients are at in their disease process. Lewy bodies dementia. What I'll tell you about Lewy bodies, it really, really looks like Parkinson's. The patient really goes through, tremors and shakes, and they're to the point, where it really progresses fast. I've had some patients where they come in and 1 minute they're walking and swallowing, and then within a few months they are not walking, not swallowing. It's faster than Alzheimer's. They just are to the point where they can't do anything. Huntington's disease, it tends to touch those patients that are younger. Again, it's very neurological, the tremors, the shakes, and they really get to the point where they can't even swallow or do care or anything. And that is permanent damage, and they end up dying in the end. To the point where they do not, they know what's going on and they can't do anything, to the point sometimes they can't even swallow. And there is a Huntington's unit out in, I believe it's Lee, Mass there, and it really, very young patients. And then I did put HIV here. Now HIV, mostly patients are really, maintaining, but if they get to the point of a severe, AIDS and everything, end stage, they can get to the point where their brain just becomes like cheese. They're not able to do anything, care for themselves, and their cognition is just very poor. Just think of the brain. Remember with, things, if there's the entanglement and things are not functioning properly, that brain is not able to do the things that we take for granted every day. So now we'll talk about delirium. Remember, it's an acute change. It's the here and now. An example could be an infection. I have a UTI. I take a course of antibiotics. It doesn't go away. Nobody does anything about it. It gets to the point where it drives me crazy. I'm not acting myself. I start doing these crazy things, and it's all due to an acute change because of an infection, is one example. Pseudodementia. That is going to be a dementia. If you think pseudo, it's not really a real dementia. That means it's not going to be for good, but the depression is so bad and it's just not treated properly. It's the point I'm not remembering. I'm acting like I'm almost having like Alzheimer's. But with Alzheimer's, it doesn't change. With pseudodementia, we can provide the proper regimen to get that patient, back functioning and remembering things. And then back to depression. You guys have discussed that with me earlier in the slides. Physical and mental decline and loss and isolation. The reason I put that back in is you think of mental illness in older adults. How many of you out in clinical have had patients with actual depression? Think about it. It's a lot of patients, and they are not on special psychiatric units. It's our patients between all the places that you attend clinicals at. So, always think, depression, how is the patient feeling? An older adult, they're going through changes in lives. Are they losing their partner? Are they losing their functioning? Are they able to drive? They're not working like they used to or working at all. So many changes are happening, and what are they doing to fill their lives? I know a lot of patients, not everybody, but a lot of patients can end up being very depressed. So it's just something in nursing that you really should take a look at when you're dealing with the geriatric population, older adults, and make sure that they are getting the things they need. And I'm not talking about specifically medication, but just getting even counseling. And sometimes they do need medication.